Been introduced. I'm Andrew Henderson. I'm a nuclear medicine physician at Levy Radiology, which is formerly Mercy. And I'm going to talk to you about targeted alpha therapy for neuroendocrine tumors. This is quite an interesting topic, but unfortunately, it involves a bit of a deep dive into physics and radiation biology. So I apologize for that in advance. Of course, us nuclear medicine physicians love these types of discussion, but it might be a bit heavy weather if it's been a long time since high school or university. Just a brief description of what alpha is. These descriptions of radiation are really talking about the type of decay that's happening. So the theranostics uses unstable atoms or radioisotopes that are giving off radiation, and most of the treatment that we give in nuclear medicine is using beta radiation. So the particle that's given off is an electron, a fast electron. That's called a beta particle. But alpha therapy is a different sort of decay where the particle that's given off is much bigger particle called, the radiation is called alpha radiation. The alpha particle is actually a helium nucleus, so it's much bigger and it gives off a lot more energy. So most of the radiation we use for imaging in nuclear medicine and radiology is using X-rays or gamma particles, and those are actually waves that can pass through a lot of tissue. Obviously, we want it to go through tissue because if you're doing imaging of a patient, you want some of the radiation to escape and give you the information about the structures inside the patient. But beta radiation, the fast electrons, a lot of it doesn't escape from the body. It hits tissue and stops and gives off energy when it stops. But electrons are reasonably small and they can pass. They can travel a short distance in tissue before they stop. And during the time they're traveling, they're giving off some of their energy, and that energy damages tissue. Alpha particles are much bigger. You can think of them like a cannonball compared to a 22 bullet. As soon as they hit something, they stop dead and they give off all of their energy in a very short space. So they travel a much shorter distance. They're much more easily stopped. They can be stopped by a sheet of paper if they're external to the body, and they give off all their radiation when they stop. Unfortunately, it's a bit more complicated than that because depending on the unstable atom that we're using for treatment, the beta particles, the fast electrons, can travel a different distance, and they can give off more or less energy. So that's called the linear energy transfer. So that describes the amount of energy that's being given off during the path that the beta particle travels in tissue or elsewhere before it stops. So those are the basic concepts. It'll become a bit more clear as we carry on discussing things. But why are we interested in this stuff in the first place? Well, beta radiation, which is what we use for conventional PRT, that's lutetium dotate, beta particles often just cause single strand breaks. So the fast electron comes off, it breaks one strand of the DNA, and that's not good for the cancer cell. It doesn't like it, but it can sometimes repair itself. So it's potentially possible for the cancer to repair itself. It's the same with any radiation, it doesn't kill all of the cancer. Alpha particles, on the other hand, often cause double strand breaks, and that's pretty much a death call for the cancer, any cancer cell that radioisotope stuck to. And that's actually obviously a more desirable effect. So, there's a lot of interest in alpha therapy as being potentially a better therapy in all cancers, not just neuroendocrine tumors. Beta emitters have a larger penetration range, so they cause more single strand breaks, and they also tend to cause more damage to the cells around the cancer cells. So if the beta particle gets past the cancer cell and is stopped by a normal cell, that cell is going to get some damage. Alpha particles have a shorter penetration, therefore potentially less side effects. So why use alpha? Well, there's some theoretical reasons why it might be better. We think it's probably, alpha particles are probably better for small metastases. We call them micrometastases. So if you've got a cancer that's spread to different tissues, but the metastases are very small, just a clump of a few cells, we might still be able to stick our therapy molecule to those few cells. But if it's beta radiation, it potentially, because of the long path range, which can be 5 millimeters or so with lutetium, the radiation will be delivered around the metastasis and not to the metastasis itself. So that's not great. Potentially, you might not affect that metastasis at all, but alpha is more likely to kill those tiny metastases. There's also this theory of different cancers. So stem cell cancers and neuroendocrine tumors are a type of stem cell cancer, are more resistant to radiation and conventional radiation and chemotherapy, but likely to be more sensitive to the type of radiation that alpha therapies can give. And also, potentially, theoretically, damage caused by alpha radiation to cancers is more likely to provoke an immune response. So one of the reasons we think radiation works in some tumors is because the cell is broken open and the internal material is exposed to the body's immune system, which then is able to recognize it as something that it doesn't want, and it can provoke an immune response. So theoretically, alpha radiation might provoke a better immune response to your cancer. Must have got to stress this is all theory. So there's a few alpha emitters that we can use in nuclear medicine therapy. The main one that we're interested in is actinium. But there's also radium, which is used quite a lot in nuclear medicine, not so easy to direct to neuroendocrine tumors. There's 212 lead and 213 bismuth are all the ones that have been considered for PRRT. In fact, bismuth was used very early on in the piece. We have this great competition in nuclear medicine where people submit their image of the year and it gets a prize. I mean, this is the sort of thing that interests us guys. This was the nuclear medicine image of the year in 2012, a patient who was treated with 213 bismuth successfully. Focus has changed more to actinium and for various reasons. And this is an image of a patient. So this is you've probably seen these sorts of images before, but this is some of this uptake is what we call physiologic activity. But a lot of these black spots are the cancer, and you can see as the patients had 2 cycles of actinium therapy that the amount of their cancer has gone away quite a lot. Now, I should say that there's a lot of these types of images in nuclear medicine. Not everyone has these sorts of responses. And in fact, a lot of the time with the neuroendocrine tumors, we're happy if the tumor just stays looking the same. So they're very slow growing tumors, and often a good result is just that the cancer stops growing for a while. However, it's fun and encouraging to see these patients have dramatic responses. That was with actinium. The big trouble with alpha therapy is that we don't really have the evidence to get funding. So this is a meta-analysis. That's a collection of all of the studies that can be found in the literature and collective results for actinium therapy. And as you can see, it's not a huge number of patients. It's not prospective, and it was a mix of patients as well. So some of these patients hadn't had previous PRT, others had lutetium and had failed. This isn't the sort of evidence that convinces funders to pay for therapy, unfortunately. What we need is prospective trials. That is trials where you take a large number of patients you give them all the same treatment, not all of them, and you compare it to standard therapy to prove that this is a survival advantage. Unless you've got that sort of evidence, it's very hard to get things funded anywhere in the world, including New Zealand. But it backs up what we believe about these therapies, which is they actually work very well, that 50% of patients have an objective response, more than 50% get control of their disease, and the toxicity is low. So obviously there's no free lunch. You know, with all of these treatments, you want to know that you can deliver treatment and that it's not going to make the patient die from something else. So, you know, you get renal, your kidneys give up, or your marrow stops working. So there was initially quite a bit of concern that alpha therapy, because it delivers so much damage to cells, might irreversibly or catastrophically damage marrow or kidneys, and that doesn't seem to be the case. So just briefly talking about side effects and how these therapies are used, actinium therapy is actually used quite a lot now for prostate cancer patients. So there's a lot more prostate cancer patients who have these therapies than neuroendocrine tumor patients, just because of the vastly greater number of prostate cancer patients. So there's quite a bit of experience with actinium being used in a similar fashion for these patients. And we know that the side effects for these patients are pretty high. Well, this is another one of these images of the molecule that we're targeting in prostate cancer. It's called PSMA. And one of the reasons we have a lot of trouble with actinium therapy in these patients is because they have very high grade uptake in their saliva glands, and to a lesser degree in their lacrimal glands. Lacrimal glands make tears. So although this stuff works very well in prostate cancer patients, they almost all end up with a dry mouth and dry eyes. And that doesn't sound like a big deal, but it's actually very unpleasant. And some patients who have actinium therapy for prostate cancer say, the outcome's pretty bad. I would rather have let the cancer get me. So that's, you know, not ideal. I mean, all of these treatments are meant to be preserving your quality of life. But here's a similar picture for the target molecule in PRT, which is the SSTR, or the somatostatin receptor. And you can see that the distribution of what we call physiologic activity is quite different. So the amount of uptake in their saliva glands is quite low. So patients don't tend to get dry mouth, they can't get dry eyes. These other organs, which are, you know, non-target organs which express the target receptor, the pituitary, the thyroid, the adrenal glands, liver and spleen, they tend to stand up to alpha therapy pretty well. So less side effects for patients with neuroendocrine tumors. So currently, what's the mandate for using alpha therapy? Well, the main mandate is salvage. So it's very hard to introduce any new therapy if you've got one that's very well proven. And the trouble is, it's probably not a problem, but the trials that proved the use of lutetium dotatate to therapy were very well done and very conclusive. So if you want to introduce a new therapy, you've got to prove it's better than that therapy. So more or less when anything new comes along, the only patients who are going to get access to it are the ones that failed conventional therapy. So at the moment, it's hard to say that there's any reason to give people alpha therapy unless they've already had lutetium PRT and they haven't responded. Those patients too, they have to still have good uptake. So the patients who don't respond because they don't express enough of the target receptor, they aren't going to do any better with actinium. So there's this, you know, at the moment, there's a small group of patients who should be perhaps given the opportunity to have alpha therapy. As time goes on, we're going to see the alpha therapy find its place amongst the therapies. And one of the things that it may be useful for is as an upfront therapy. So when you're ready to have PRT, perhaps having a single cycle of alpha therapy will get rid of all the small metastases for you so that they're unlikely to grow. and you can then go on to have beta therapy. This is all conjecture, but these are the sorts of ideas that we're looking at to see whether alpha therapy might have a place in conventional therapy in the near future. But we need the trials. Is it possible to have this treatment for salvage in New Zealand? Technically, it is possible. We have given actinium therapy to some prostate cancer patients. Some New Zealand patients have gone overseas to have alpha therapy. But the trouble with actinium, which is the main radioisotope we're talking about, is the supply is erratic, it's expensive, and it comes from places. So actinium is made in Israel, comes from Russia and Ukraine. So as you can imagine, the worldwide supply of actinium is in jeopardy currently. And that makes it more expensive and more difficult to source reliably. So what are the alternatives? Well, I think one of the other ones I mentioned was lead-212. So this is quite interesting because it's probably equivalent to actinium. There's much less evidence for it so far, but it's potentially more easily available and cheaper than actinium. So it's a space to watch. And I've already talked about bismuth. So I'm going to go on and talk about just a couple of other areas of interest and other radioisotopes that aren't alpha therapy but may also have a role for PRT. One of them is something called yttrium. Now, yttrium is actually another beta emitter, but the beta particle that's given off is much more energetic than lutetium, and it goes much further. Now, we've already talked about maybe not such a good thing in some cancers. In smaller cancers, you don't want all the energy to go into the tissue around the cancer and damage it. But for big tumors, for big metastases, it may have an advantage. And in fact, the first radioisotope that was used for PRT was yttrium, and with good effect. And when lutetium came along, a lot of centres combined these two radioisotopes. So they used both of them either injected in the same syringe or given sequentially in order to get a sort of a synergistic effect. So to treat in a closer range within a tumour, but also to get the bigger range that could go further in tissue and treat a larger mass. And it's still used a lot overseas. It's not funded in New Zealand, but there are situations, for instance, where you've got a cancer that's very large, where you know the lutetium might not be so effective, where yttrium can be used. The other advantage of yttrium is it's a little bit cheaper than lutetium, and it's reasonably easy available. So that's something that should be on the horizon in New Zealand, which is possible to make already in New Zealand, should it be required. And then just talking about the possibility of synergistic treatments, there's this stuff, terbium. So terbium's the red hot topic in theranostics at the moment because it gives off 2 or 3 decay products which are useful for treatment. One of them is beta, and it gives off a very similar beta particle to lutetium that does similar things, but it also gives off some decay electrons, conversion electrons, and Auger electrons. And Auger electrons are interesting because they travel slow and they damage tissue in a short pathway, very similar to alpha. So here's another picture, a stylized picture of DNA showing the beta effect and the alpha effect and the Auger effect. The Auger effect is a bit like alpha. It's like alpha light, if you like. So this single radioisotope offers a sort of a combined effect, which is like beta, which has the advantages of a beta therapy and possibly of an alpha therapy. And we're already looking at that for use in prostate cancer patients, and a few New Zealand patients have had terbium therapy. It's potentially possible for PRT as well, and there are some early radioligands which use terbium which are being looked at for possible use. So this is some of the other fringe radioisotopes therapies that are possible. So should New Zealand patients be having these treatments? Well, certainly not up front, and they're not funded. They're pretty expensive, so almost $30,000 a cycle if you have to pay for it yourself. But it should be something that is on the horizon for patients as a salvage treatment, either in New Zealand, which is going to be possible in short order, or an overseas clinic. And already in meetings discussing neuroendocrine tumor patients, the patients who potentially might benefit from these sorts of therapies are discussed, and one or two of them have been offered the opportunity or asked if they would like to fund these therapies for themselves, either in New Zealand or overseas. So it's on the horizon. I'd like to see us move towards funding in New Zealand. It's possible that if we can get some better trials, that it might be possible to get the high cost funding pool, for instance, to pay for some of these things.